Great, thank you. All right, we'll turn it over now to Phil Kregor from Nashville for his case.
Good morning. It's really nice to be here. We're very sad that the OTA won't be here, but we're going to bring you a little piece of Nashville this morning. This was Nashville at 8:30 on a Friday night. I had just finished the OR for the day. I was walking down the hall to leave the hospital, and just kind of nonchalantly, the general surgeon said, "Hey, Phil, I just finished the next lap on a lady. She's pretty unstable. I think she has a pretty significant pelvic fracture and some arm fractures, room 8. And I happened to be passing by the radiology technician with the machine, looked at the x-ray, and saw this. So this is our case for this morning. She's a 21-year-old female. She had a motor vehicle collision. She was brought within about 10 minutes from the ER to the OR for an emergent laparotomy for a pretty significant splenic injury. Her lactate was in the 4 to 5 range. She was on the table when I got that message. Her BMI was about 42, and she was noted to have a pretty significant posterior right buttock soft tissue contusion. Oh, by the way, she had about 3 to 4 centimeter open bilateral humerus fractures. And this, again, was her AP radiograph that they actually had obtained for a sponge count after their emergent laparotomy. And I think it's really good to pause and just say, what information are we really seeing on this AP pelvis? So the first thing that I think is pretty noticeable is the femoral head is medialized and not under the articular roof. You see some impaction of the radiographic roof there. And then I think a good clue, and it may not project so well on your computer screen, but there's an inferior ramus fracture on the contralateral side. And I think you can see pretty nicely that there is a left SI joint injury. The other thing that I notice is that the right innominate bone, or the right iliac wing, is externally rotated. If you look at it in terms of the spine, that's a pretty good AP radiograph. And we're seeing more of the iliac crest on the right side. So this shows that there's some external rotation of the right side. And oh, by the way, she has some femoral acetabular impingement, which is asymptomatic but radiographically apparent actually on both hips. So like most of the times, the AP pelvis gives us a lot of information. It's 8:30 at night, and oh, by the way, there's also a small cortical break in the superior aspect of the ischiopubic segment near the greater sciatic notch. So there it is. She's on the table. The general surgeons tell me, look, she's pretty unstable, but if you need to do something that's absolutely necessary, please do that, but be quick about it. And don't really have the best, certainly orthopedic trauma team at about now 9 o'clock in the evening, but could proceed with anything that you feel is really urgent. So I felt some of the priorities were to, in fact, while they were closing the belly, I prepped out the arms relatively quickly and debrided the arms and put some splints on. And then the question is, what are we going to do initially with the right hip?
Phil, did you have the did you have a chest, abdomen, pelvis CT from a trauma assessment, or had they gone right to the OR without it?
Yeah, there were no other injuries, to be honest, Mark. I don't know whether that, I can't recall whether or not they actually got a chest CT and abdomen CT. I think that it's a very high likelihood in our institution that that was obtained in the first 5 minutes. Yeah.
Yeah, so just wondering if you also had some CT information about your pelvic injury available to you.
Uh, we did. We did have some information, and I can show you that CAT scan. Quite frankly, things are moving a little bit quickly because they really want me to get out of the room. And so, that's why I think I make the point of really using all the information on the AP pelvis. I probably scrolled through the CT scan very quickly. I don't really recall. It's been over about 15 months now. So the question is what are we going to do initially? I'll just kind of back that up to you, Mark. What are your thoughts here in terms of, I took care of what I thought was urgent in the arms, and the question is what to do with the right hip.
Yeah, absolutely. So I'm sure that the comments from the faculty will be try and get the hip reduced, and while she's paralyzed, still hopefully intubated to be able to do that. She's obviously not going to be stable for any more significant intervention there, but there is some posterior pelvic ring injury, and that's why I was asking about the CT, because an understanding of the posterior pelvic ring injury, if the patient was a little more stable, maybe there's something you could do to set up your next surgery a little bit potentially.
Yeah. And I'll tell you, this is real life. She's also on a regular OR table, which I'm not too proud of, but
that's a daily occurrence.
Yeah. And so certainly we could have switched her to a completely radiolucent table, but this was a X-ray taken underneath the patient, and we don't have a radiolucent table. She's pretty unstable. I think that what I pointed out before, she has bilateral SI joint injuries and no other abnormality. And my initial management was, as I said, debrided and splinted both of the open humerus fractures. I attempted to reduce the right hip. I was hoping that the femoral head would go underneath the radiographic roof. That was not a satisfying thing. And I also placed her in distal femoral traction. And this was the intraoperative plain film. And I think we have another film that just documented that when she got back into bed, she was at least not wedged in between the transverse component of the fracture. Maybe John Eastman might comment. John, Dr. Eastman, what do you think here? Are we okay here for the time being to live through the night, so to speak?
Yeah, Phil, I think this is very much similar to the first case that Dr. Sims mentioned in terms of this patient is not hemodynamically hemodynamically unstable and is not ready for any sort of intervention. I think with that medialization, I think I tried to make the point in my lecture about the combined pelvic ring and acetabular fractures, where you're looking at the SI joint and how that the left SI joint is tethered through the symphysis, which is now onto the ischiopubic segment, and that's somewhat tethering that head back down through the ligamentum into that position. And also with the right sacroiliac joint, it really can't get back out underneath that intact dome. And so I think, you had mentioned that she is on unfortunately on a regular non-radiolucent table, but in that femoral head position, that's probably the best you're going to get, which I think is acceptable. But I think if possible, I would love to consider getting her into some sort of circumferential wrap and or an anterior based external fixator to close her pelvic ring, which will help with hemodynamics, but then will also help with reestablishing her dome on the right side to where it's supposed to be in space. So that way her head can now get to where it needs to be and sit there.
Yeah, I think those are great points, Dr. Eastman. So she recovered. We study, just to Dr. Riley's point, this is the CT scan. So the answer is, Mark, we did have a CT scan, now that I look at this, prior to going to the operating room, and these were asking for some reconstruction cuts. And there you see a pretty significant left SI joint injury and some mild right SI joint injury. And please keep in mind that there's a gantry effect. So probably based on the AP pelvis, I would make the argument that the right side is also more injured than is represented on this CAT scan. And here's a 3D reconstruction, again showing the left SI joint injury, the pubic root fracture on the left side, and then what turns out to be a transverse fracture. And you'll notice there that there's a cortical fragment at the superior aspect of the ischiopubic segment. There's a 3D reconstruction of the posterior aspect. You'll notice there is no posterior wall fracture. We did not obtain true Judae's films here because this is a case where I would be concerned about what happens to the femoral head if one was to try to get Judae's. And so what we're really talking about here is acetabular fracture with associated pelvic ring injury. And my goals are really to discuss how an SI joint injury affects the ease of reduction of a transverse fracture. I think that's an important point. Then to understand the surgical tactics for reduction of the transverse fracture in such a situation, and think about the options in terms of sequence and positioning for such a situation. So just going back to some of the things that we've learned in the past weeks, we've learned that a transverse fracture usually is addressed from a standard Kregor-Langenbeck. Occasionally, especially with pelvic ring pathology, we might utilize an ilioinguinal approach or the inner pelvic anterior approach, and very rarely an extended iliofemoral approach. So going back in terms of the Kregor-Langenbeck, we'll remember that we utilize distal femoral traction, distraction of the hip joint. We can use an ischial tuberosity Schanz pin. We can use angled jaw clamps and other clamps through the greater sciatic notch. And we can also use the so-called screw-to-screw clamp family, namely the Faribuff and the pelvic reduction clamps, as is seen here schematically from a Kregor-Langenbeck. But going back to our case, we recognize that there are some complicating factors if we have a transverse fracture, and those include an ipsilateral or contralateral SI joint injury, a sacral fracture, anterior ring pathology, and certainly the transtectal pattern. So this is our situation after the patient is in skeletal traction. And so the diagnosis is that of a transtectal transverse acetabular fracture. We have both a right and left sacroiliac joint injury. We have a left superior and inferior rami fracture with the pubic root being involved. And we also have a small amount of articular impaction at the transverse fracture. So what are our options? Well, certainly one could go through a whole list of options, but I tried to list here, I think, all of the potential ones, and then I thought we could open it up for a few minutes for the faculty to kind of discuss through that. I think that one could do either supine or prone iliosacral screws, and then perform a prone Kregor-Langenbeck for a right transverse fracture. The second option might be a prone Kregor-Langenbeck for the right transverse fracture and then iliosacral screws. A third option might be supine iliosacral screws combined with an anterior approach to the right acetabulum. And then finally, open reduction of the SI joints with an anterior approach to the right acetabulum. So let's just think about concern with iliosacral screw placement first. I think the problems that I can get into is how do I know that the SI joint is perfectly reduced? I think perhaps that, thinking about the left SI joint, one might make the argument that if you were going to use just an iliosacral screw, that an intraoperative CT scan, if available, would be helpful. And then the question is what if the SI joint is not perfectly reduced and you are trying to reduce the transverse fracture? How do you deal with that? Conversely, let's think about fixing the transverse fracture first. Does external rotation of the left hemipelvis allow for appropriate reduction of the transverse fracture? And will prone positioning make external rotation of the especially left innominate bone in this case worse, and therefore make the transverse fracture harder to reduce for the reasons that Dr. Eastman already talked about? And how about the question with the left pubic root fracture? Do the SI joints even matter because you have so much laxity in the pelvic ring? So I'd just like to maybe get some of the other faculty's opinion in terms of surgical sequence and positioning. And I'd like you to break it up into that. First, what are you trying to address first? And then secondarily, what position are you going to start out with and what position are you going to go to? Maybe some of the faculty could comment on that.
Phil, while they're getting ready to chime in, there was a really good question from a participant that occurred to me as well, which is that should you image the superior gluteal artery vein with an angiography or a CT angiography preoperatively to know whether or not it's in the fracture before you choose your approach for the transverse?
So my read on this particular fracture, and we could go through the 3Ds as well and the plain films, is that while the superior gluteal is at risk in any transverse fracture, I suspect with the displacement, I didn't read this as one that would be commonly involved. So I don't think for me that that's going to affect the surgical approach. You will recall, however, that she did have significant soft tissue abrasions, contusions about her buttock, and that her BMI was 42. I think those are two soft tissue concerns. I think it's always good to think about the superior gluteal, but at least me personally, that's not something that I would get an angiogram on in this particular pattern.
Okay, other faculty members, comments on your surgical sequencing?
I'll take a stab to start it off with. So I think your ability to reduce that transverse fracture on the right side with the SI joint gapped open on the left is going to be, and displaced, is going to be nearly impossible. Your point is good that there is a slot point in the front with that ramus fracture, but I would be willing to bet there's enough good soft tissues attached to that with that SI joint being that far off, you will not get that transverse fracture reduced. So I would probably do an open reduction of the left SI joint, and I probably would do that first. And I mean, you could do that anteriorly or posteriorly, but I probably would do it anteriorly for the reasons you said. And then I think what you're left with is the left side, and that SI joint. Again, look, I don't have all the x-rays to look at, but the ones we saw, it looks to me like it's just gapped a little bit anteriorly, which I think happens quite a bit with these transtectal transverse fractures when the head goes inside the pelvis like this one did. It's almost like the head is forcing it out. And so for me, for those, I tend to address the acetabulum next. And I probably, whether I would do that supine or and you go do anterior or prone, I think Depends a little bit. I didn't see how clearly that quadrilateral surface was broken, but that adds a lot of complexity to it, because that's kind of where, if you do it from the back, that's kind of where some of the clamps go. And if you're doing it from the front, that's how you judge your reduction a little bit, you know. So my preference would be to do an anterior SI joint on the left side, then flip her over, do a Kregor back, and do the acetabulum second. And then if I thought I needed to do something to the SI joint on the right at the end, I'd do that last. And then maybe, then I think at the end, I'd make a decision whether I thought that ramus needed anything added to it or not. But if it did, it would just be a screw or nothing.
So Dr. Sims, I think that's a really logical sequence for me, but I'd just like to push you on a few things. The first one is, what has been your experience if you would turn this patient prone and do a Kregor Langenbeck and say, I'm gonna, because we all agree that the acetabulum is the most important thing. If you turn this patient prone and say, I'm gonna do the transverse fracture first through a Kregor Langenbeck, what's gonna be the situation? What do you predict?
Well, you know, I suppose you're getting at, are we going to make the SI joint worse and make the ramus worse on the other side? And I think that certainly is a possibility. Again, I think of it almost like a ring, though. It'd be like if you close the symphysis, the SI joint tends to close down in the back. I think if you close that acetabulum down, which I think you could do with clamps, that the SI joint would close down, and then you can decide if you think you need to add fixation to it or not. But your point is good, and you have to show me that quadrilateral surface again. I'm not sure how well you could judge the reduction. You know, you'd be judging it. You have a big surface area posteriorly, but you only have your finger to feel on the inside, and you have to place clamps to the notch. And if that, I didn't see how much of that quadrilateral surface was broken, but if it's a lot, that might force me to want to go from the front.
Yeah, it's a lot, and I guess the point I was trying to drive home, which I agree with, and what you said is, I think if you put this patient prone first, the significant external rotation of the left hemipelvis is going to make it very difficult, if not impossible, to reduce the transverse fracture.
No, yes, so I said I would do the left side. I would do first. That would be the first thing I would do, and I would do that supine. Yeah.
Right. Yeah, I'm agreeing with you. But the second point is why not just put in an iliosacral screw? I mean, Dr. Rout and others have really shown us some very nice cases where they get really nice reductions with a percutaneous screw. What are your thoughts on that? I heard you go completely to an open reduction right away.
Well, I think I think that if you can get a good reduction and you're sure of that, you know, if you could, I guess you could put a Schantz pin in the anterior inferior spine. You could try to rotate it, and if you felt like you could get a good reduction, you could consider that. In my hands, I'm not as adept with doing that as some others are. So I would tend to want to see this and make sure I got it right, because having this off is going to really complicate your ability to get the ischiopubic segment on the transverse fracture is going to tend to follow the left hemipelvis. And if it's not reduced just right, I think you're going to have a hard time, even with that ramus fracture in the front, it will complicate your ability to reduce that transverse fracture.
So if someone were to say, I'm going to start supine, I'm going to put an external fixator on, and then I'm going to stabilize both sacroiliac joints because the rami are going to be a relief point, do you think that that's a sufficient reduction of the pelvic ring to allow you to reduce the transverse?
I don't know the answer to that, but I think it would be hard to get that right side reduced well, even with an external fixator with the head where it is.
Yeah, and I think that's the point is that we don't know, right? You can give it a try and hope that the ramus gives you enough slop to reduce the transverse, but until you start trying to reduce the transverse, you won't know if your pelvic ring malreduction is affecting you. And if once you find out that it is, you got to start over from scratch.
Agreed.
I think that's a really good discussion. So the thoughts that went into my mind, and the issues were, number one, a relatively large cortical fragment that was mostly anterior on the superior aspect of the ischiopubic segment. Number two, the left sacroiliac joint. And number three, her body habitus. And number four, the relatively large posterior contusion on her buttocks. And so what I did is exactly actually what Dr. Sims talked about. So an open reduction, you can see there, that's a open reduction along the internal iliac fossa, seeing the L5 nerve root. And there are two plates across the SI joint, which was first reduced with a screw-to-screw clamp and with aid of a Chance pin in the iliac wing there. And then for added stability, I placed an iliosacral screw. And then we went to the transverse fracture through an ilioinguinal approach on the right side. And you'll recall that Dr. Riley asked me the question, on a typical transverse fracture, why do we normally go with a Coker-Langenbeck? And the answer that I gave is our ability to reduce a transverse fracture is generally easier. Our reduction tools are better from posterior, and it is challenging in a case like this for me to reduce the transverse fracture, not impossible. But the continued concern is peripheral gapping posteriorly, and is also in dealing with working around the iliopsoas in a patient who's relatively large with a BMI of 42. And then in this particular case, the concern is the separate cortical fragment superiorly. So these are some of the tools that can be utilized. You see a screw-to-screw clamp there, more peripheral around the transverse fracture. And we also utilized a short angle jaw forcep. And you can also see that we have a Chance pin in the proximal femur. And we're certainly challenged because of the separate cortical fragment here. This is a actually out of sequence film where I actually had to take out that screw. You can see that's a malreduction, and we certainly had several iterations of the reduction attempt. But in the end, we did what Dr. Sims talked about, which was to first do an open approach of the left SI joint, address the right acetabulum through an ilioinguinal. You can see there's a separate cortical fragment there superiorly. And then we placed two additional plates across the now minimally displaced SI joint. And you can see, you know, if you have things correctly reduced, then our rami fractures on the left side should be minimally displaced, and they are. But you can certainly see here, this is the problem, at least for me, for a transverse fracture, is that we can have some peripheral gapping, especially posterior. But there is the situation in terms of the reduction on both views, the initial postoperative view. And there's the postoperative CT scan demonstrating an appropriate reduction of the sacroiliac joints and the transverse fracture. Really open it up for any critiques, suggestions, or comments, but this is the patient at 1 year follow-up. Fortunately, and pretty impressively, she's lost 40 pounds, mostly because of exercise, I'm told. She's able to jog, but she did have a need for a pretty significant debridement and skin grafting of degloving injury in the right buttock. So in conclusion, let's just remember that SI joint injuries and sacral fractures and anterior ring fractures significantly complicate transverse fracture reductions. Transverse fractures can occasionally be treated with an anterior approach, especially with multiple pelvic ring injuries. There may be an advantage to supine positioning with an anterior approach, if the acetabulum is possible to be reduced with simultaneous exposure of the SI joint. And just like from posterior, we're going to utilize the short angle jaw forceps, screw-to-screw clamps, and Chance pins as common reduction tools. Thanks very much.